Hi, I'm Bob McCoskrie. Welcome to Family Matters. Well, the euthanasia law has kicked in and it is now legal and available in New Zealand. What's the experience overseas, and especially in our trans-Tasman neighbours in Australia? And we've gone to a specialist to ask, a palliative care specialist. It's Professor David Kissane, who is the Chair of Palliative Care Research at the University of Notre, Australia, and the Cunningham Centre for Palliative Care Research at St Vincent, Sydney, also the Department of Psychiatry, Monash University. David, it's a pleasure to have you as part of this podcast.
Thank you, Bob. It's good to be with you and to be talking to people in New Zealand. Thank you for having me.
Now, we always like to beat you at rugby, but it seems like you've been beating us at this particular road to euthanasia. With my understanding is that virtually all states have either passed it or have legislation. I think it's just New South Wales is the last one to kind of cross the line. Is that correct?
Yes, New South Wales is the last state debating it at present with a bill before the Parliament. And our territories, the ACT and the Northern Territory, would be legislated for by the Commonwealth Parliament. And so from that point of view, they also haven't brought it in yet. But we look like we'll be close to being a country that uniformly will have laws for medically assisted dying.
And you're based in Victoria now. You've had it for just over 2 years, I think it is.
That's correct. It came in as legislation in 2019, and we've now completed 2 years of formal reporting on that process and seen some 300 odd people make use of the legislation to end their lives. 15% accepting the injection of a doctor as a treatment, as a procedure that ends their life, but 85% taking medication at a time of their own choosing, very often in the privacy of their own home, to control their dying.
So let's have a look at some of that data coming out of Australia shortly, but can we just take a step back? Leading into this push for euthanasia, how were you pushing back? What was your warning to states that wanted to legalise euthanasia, and probably still is your warning now?
Well, I think John Stuart Mill put it very well when he said that power should only be exercised over a civilised community when it's to prevent harm to others in society. And so we're used to legislation that limits our freedom, and we would not really pause to argue about road laws or about smoking in public, legislation that may be about drinking. I think firearms are a very good example, because we have a society like America where the right to carry a firearm is deemed to be a very important freedom, a social right, and yet we watch with horror at the number of children that are killed in schools when a gunman goes wild. And I think the lack of firearm legislation is a very good example of how a society can fail to prevent harm to others because of some desire to have an autonomous right for a few, for perhaps a smaller minority. One has to really work out whether you have legislation which helps people have a very comfortable dying of their own choosing to advantage that group, or is there a risk to a vulnerable population of people, vulnerable because of their illness, because of the predicament they're in, who could be pressured by family, or who could be mentally unwell and take their life. So legislators are always trying to get that balance right, and I think legislators should err on the side of protecting the vulnerable and in that way maintaining the avoidance of harm in society. But the euthanasia legislation and New Zealand's legislation privileges the freedom of those who want to exercise that freedom and control their autonomy is privileged over protection of the vulnerable.
Yeah, and that was one of the arguments that we put up, was that the vulnerable will be at risk. And I want to look at specific information that you've talked at. I've had the privilege of hearing you speak in advance, so that's why I wanted to get your message out to more New Zealanders to be aware. But perhaps I put this question at the end of our run sheet, but perhaps I can bring it right up to this now. And, you know, one of the strongest arguments for assisted suicide euthanasia was that it seemed like everyone knew of a loved one or a friend who had died, and it hadn't been a pretty death. You know, I mean, death is never pretty, but it was a difficult, drawn out. Perhaps it seemed like they were in lots of pain, and so therefore there was this feeling that, you know, it was the decent thing to do. The old statement, well, we put dogs down, you know, who are in pain. Why can't we do that for human beings? What's your response to that argument?
Well, I think, first of all, you're talking about society's lack of familiarity with death and dying in our modern era, which is a success of medicine, really, in keeping people alive for much longer. Back 100 years ago, death was much more familiar because people lived in large families, and most families had 2, 3 or 4 children die from an infection before they reached adulthood. Death was familiar. The average length of life was about 50 years. Today we're well into the 80s. We're not as used to seeing dying until COVID came along. But in the old days, death from TB, death from infection was very common, and death was familiar to society. So when people haven't seen several deaths in their family, when they're new to the experience of death, sometimes as adults they watch an elderly person dying and they project themselves into the shoes of that individual, and they see themselves with a sense of some horror with that lack of familiarity. Sometimes a little bit of confusion, delirium at the end of life can look very ugly to someone who looks on. And it's not such a terrible experience for the person going through it, who acclimatizes to the frailty, who comes gradually to accept their dying and lets go of life that way relatively peacefully. But the onlooker is potentially shocked and thinks this is a bad deal. And so we want to avoid that, protect against that. I think that becomes a very strong reason for people to want to be in control, a strong aspect of personhood in this modern era. And in wanting to be in control, people tend to think that to control their dying that way is what they would choose.
Okay, so let's talk about that vulnerability, which you raise a concern. You say that the vulnerable are more at risk, we need to protect them rather, and that outweighs the right that some people are claiming. And in your presentation, you talked about vulnerability and depression. So firstly, I'll put up some slides and maybe you can just speak to them. Hopefully you still remember them from the presentation. And the first one was this one about vulnerability. Can you just talk about some of the issues that are being faced by patients who are experiencing or are facing terminal illness?
Yes, this is a commentary on what constitutes suffering for people, because suffering is often put forward as a fear that people want to avoid. And when people have studied the causes of suffering, they generally reflect poor medical care or inadequate palliative care. For example, poor symptom control, which might be lack of adequate pain control. When we've studied depression and anxiety disorders in oncology populations, we see that they're often undiagnosed. Oncologists assume that the tears that a patient shares are tears that are due to grief, due to distress at the illness, rather than recognizing that the person has developed a depression. Unaddressed existential fears, fear of dying, fear of loss of control, the uncertainty, angst that develops because of the threat of death. unrecognised family distress, where family arguments, lack of cohesion, lack of communication create difficulties. These often create stresses and distress for family members. Fatigue, burnout, that state of becoming demoralised, of dropping one's morale, feeling that life is losing its value, its point, its meaning, and communication breakdown. These are the common causes of suffering that we see. Palliative medicine, of course, can control pain. If you can't do that with medication, then you can certainly give an anaesthetic block and regulate pain. But the difficult to control causes of suffering tend to be in the existential and psychological domains, and they're a challenge for medicine, and yet that's what palliative care seeks to do. So very often there's this tension between good palliative care and euthanasia, and if we can improve the standard of palliative care delivery in a country like New Zealand, then the need for euthanasia should be very, very minimal.
Okay, and then you talked about the types of vulnerable patients, and I mean that's a big list. That's a lot of people that are vulnerable in our community.
Yes, it is, and it just shows the extent of potential harm if people are allowed to act inappropriately when they're vulnerable, when they're under stress and strain. So the mentally ill, as a cancer psychiatrist, the mentally ill have been a big concern for me, where they may act on the spur of the moment, where they may lose their decision-making capacity. But families can have conflict and be dysfunctional. People can receive poor medical treatment. They can have a misdiagnosis. They can be inadequately managed. Doctors don't always have good skills. Doctors can sometimes make mistakes, and losing a person's life because of a misstatement of an assessment of poor prognosis, a lack of awareness that a new treatment around the corner is going to really turn the cancer around. I've talked about the unfamiliarity of death to the person who's watching on. Fear of dementia is a very good example in our societies. You know, we all fear that kind of cognitive impairment that could develop. And being disabled, having a neurological disease like Parkinson's or motor neuron disease, tough illnesses, but they make people vulnerable. And so vulnerability is a very big group in society, and we need to protect people who are vulnerable as a society.
Well, I would imagine, and for anybody who receives a diagnosis that suggests that their life is going to end fairly soon, or sometime in the near future, that would immediately send them into a depressed state. That would affect their mental health immediately, and they wouldn't necessarily make rational decisions. So you did talk about this mental illness towards the end of life. What's the research showing in that area?
Yes, about 1/3 of people in palliative care are vulnerable to mental illness. And there we've differentiated different types of mental illness. Depression rates of between 11 and 16%, particularly increasing rates of depression as you have greater frailty and move towards palliative care. And then people who struggle to cope, who drop their morale and don't adjust well to the predicament that they're in. About 15% of people in palliative care become demoralised. The research has shown that demoralisation as a state predicts the likelihood of giving up on life, of suicidal thinking, more so than depression. Psychiatry conceptualizes depression as a loss of pleasure, a loss of happiness. The loss of happiness doesn't automatically lead to a desire to give up on life. But it's when you become hopeless, when life loses its point, when meaninglessness steps in, then you develop the thoughts of, is the wish to die stronger than the will to live? normally the will to live is very strong in our people. That's our flourishing human nature, to have a strong will to live. But if in fact you lose a sense of self-worth, meaning, hope, or you become too ashamed, then they're the mediators that lead people to develop thoughts of dying, and a wish to die can develop.
Now,
towards the end of life, Bob, you actually see quite a bit of ambivalence. You know, as you talk to a lot of people who are dying, you can find that people say, I was thinking the other day I'd let go of life, I'd give up on it because it's just getting hard. But today's a good day because I've just seen my family and it's been beautiful. And so this will to live with the wish to die is a normal process of coming to terms with the change in bodily health. And a fluctuation about that and ambivalence about it all is normal. But when you convert it into a law that allows people to act and take some pills fairly quickly, then you create the danger that people will act just when they're struggling with that ambivalence about what they wish to do. And therein lies a grave danger, I think.
Yeah, and I was fascinated by the study that you quoted from the Dutch in terms of the link between depression. Can you just talk to this?
Yes, so this is just a standard example of dozens of studies that are there in the literature that look at people towards the end of their life and assesses whether or not they're depressed. And, you know, about a quarter of the people in this cohort were depressed, and the depressed were more likely in the Netherlands to put a request for euthanasia forward. So the rate of that request for help to die was 4 times greater when people were depressed than people who were happy and content with life that way.
And that's probably not surprising, is it?
No, I think depression has always been a cause of suicidal thinking. Demoralization and poor coping, poor adjustment have been causes of suicidal thinking, and particularly the development of hopelessness. Of course, the danger is if an oncologist unwittingly suggests to a person that cancer treatment's not working anymore, and they start to suggest that they're running out of options, they can create a sense of hopelessness in people very easily. And so sometimes poor medical communication, which instead of focusing on ongoing ways of treating and helping the person in a more person-centered way, too much of a focus on the disease and on the idea of curing cancer can unwittingly create this sense of hopelessness in patients, which then makes them vulnerable.
Well, that was one of the things they said about the New Zealand law. They said it was a safeguard, is that the doctor cannot suggest it, that the patient has to be the one that brings up the topic. But as you say, the diagnosis, the prognosis, just the general discussion is, because it's now an option on the table, doctors may not need to raise it anyway. It's going to be part of the option, isn't it?
Yes, look, as a cancer psychiatrist, I've been always referred people who are struggling with their coping and who may wonder about whether they'll suicide or not. Psychiatry's spent all of its life as a discipline trying to prevent suicide. People think of ending life very easily, and it doesn't have to be suggested by medicos. It's a ridiculous safeguard, really disabled. The doctor can't raise it. It comes into human thinking very easily. An important question, of course, predicting the future is, you know, what will happen to the rate of suicide in New Zealand in the years to come. And I'm impressed by the evidence that has come out of a small number of studies that suggests that society increases its rate of suicide when it allows medically assisted suicide to occur. And this comes about because suicide is normalized. You can see this in the Netherlands and in Belgium at present, where suicide, medically assisted suicide for mental illness is now normal in those countries.
No, I think you actually had a slide on that, didn't you? I think it's this slide. Is that the one?
That's an example of one, where you've got a comparison between Belgium and France. France is in the blue, and you can see that the rate of suicide is steadily going down. But in Belgium, it's plateaued. And interestingly, in the European Union, Belgium's right up there amongst the top countries for its rate of suicide, with only Slovenia and Lithuania, fairly socioeconomically deprived communities, having more suicide. So I think when you allow medically assisted suicide, then you normalize suicide in the community. People get used to it, and it becomes easier for people who are in trouble with mental illness to think, well, if you can end your life because of a physical illness, why not do it because I'm suffering with a mental illness? And it can increase that rate of suicide.
Now, you've been in Victoria, it's been there for 2 years, and one of the things you talked about was the typical Victorian patient that you're coming across in your work. Does this sort of sum up the general person who is likely to apply for euthanasia?
Yes, to think of VAD as it's called in Victoria, and it's become part of the common language. That's becoming a common reason for referral. Lots of patients contemplate the struggle at the end of life, and so they ask the question, should I be considering VAD? Typically in the past, I got referrals of people who were deemed to be depressed or deemed to be coping poorly and to have become demoralized. But now one sees people who are being referred because they're thinking of VAD. And that slide that you've got there just talks about a patient who had a history of several weeks of feeling hopeless, fatigued, without any happiness or pleasure in their life, loss of interest. Life had become pointless, and they were frankly suicidal. They had a major depression, and they were open to having that depression treated with antidepressants so that within a short period of time they could regain their enjoyment of life and their wish to life. So that example that you've got there saw a person then having good quality of life over several months and embracing that life. But the danger, of course, if that depression is not recognised, is that VAD is then followed through on, and people are ending their lives for the wrong reasons.
So, I mean, our law says that mental illness is not a qualification for assisted suicide, but you're saying it's the link between having a terminal disease or a bad disease of some sort and then that depression kicking in.
Yes. It's also predictable that in the future the mentally ill will ask for the law to be modified. Canada has that as a sizable debate. And the history of Belgium and the Netherlands is that over 10 and 20 years, gradually they allowed more and more cases of the mentally ill to access euthanasia. So now when you look at the people with psychiatric disorders in the Netherlands and Belgium, not only are many of them cases of patients with depression, but we see suicide for autism, for anorexia nervosa, for grief, for schizophrenia or psychosis. We see many people receiving and accessing euthanasia for mental illness, and that becomes fairly normative. An interesting study was done in Canada asking 500 odd psychiatrists about their attitude to suicide being available, medically assisted suicide for the mentally ill. And if you look at the factors that led 2/3 of them to not support MAID for medical illness, one saw that people thought they'd changed their commitment to the patient. By that they mean they'd stop trying. That if people had a more difficult mental illness and there was a lot of distress, that they'd stop trying for a period of time. But importantly on that slide, it also pointed to in the red that many psychiatrists knew that they had prior patients who would have qualified for medically assisted dying, and yet they recovered. And so they could see that difficult to treat patients could end up receiving assistance to die instead of people just persevering with their treatment and ending up getting them better.
Philip Nixty was one of the proponents of the bill in New Zealand. He came over here a few times. He would run these clinics showing people how to commit suicide, give them the medication. And actually I got into a bit of a Twitter war with him because he said that people had a human right to suicide. That was a fundamental human right. Now, you've actually had involvement with him. Perhaps you could just tell that story, and I'll just show this this slide here.
Yes, I used to get into medical education discussions in the 1990s with Philip Nixty, and doing that to educate students and young doctors. And after one of those educational sessions, I said to him, why don't you publish the medical cases that you assisted people to die in Darwin when the Roti legislation was there in the 1990s, 96, 97. So he allowed me to travel to Darwin, and he presented 7 medical records that we spent a week studying. We saw a number of ways in which poor medical care was being delivered to those patients. 4 of the 7 had a clinical depression that was unrecognised or being ignored, often with low doses of antidepressants or old antidepressants being used. And you can see a profile there in that slide of those cases. But I think the next slide actually then summarises the gatekeeping roles, or what are now called safeguards. And it was very clear that those safeguards had failed, that the vulnerable weren't protected. There are examples of people who had some pain and they would have been greatly helped by radiotherapy. But Darwin didn't have radiotherapy. People had to fly down to Adelaide to access that, and that tended not to occur. So there was a poor quality of medical care, and depression went untreated, and one could conclude that the safeguards failed. Nitsky, of course, liked that argument because he wanted to get rid of all safeguards. He thought that people should be much more freely able to access suicide.
Fundamental human
rights. I think an important lesson with those safeguards was that ultimately in Darwin, the coroner of that day was given responsibility to have oversight of the medical care and to make sure that the rules were upheld. And the coroner failed to in any way look at any of those cases. There was never an inquest, never an investigation. Years later, I met that coroner and I said to him, why didn't you do a little more? Because there was clear neglect of the legislation, the safeguards weren't upheld. Why not do a bit more? And he said, well, he perceived that the community wanted euthanasia at that time in the Northern Territory, and it would have been very politically incorrect for him to step in and create a fuss investigating those cases. And I think that's what happens when countries then set up review boards, because this is the standard of care, that you to create a safeguard, you constitute a review board that's meant to look carefully at whether the right thing is done by these patients. Review boards just look at statistics. They see if boxes are ticked. Has the form been filled out correctly? They don't look at the clinical detail of the stories of what's gone on. And so they're an inept means of really oversighting the quality of care to ensure that that's sustained.
And that was one of the concerns we raised about our law, is that if there's anomalies in the paperwork, they don't have to investigate that. They really are just ticking the boxes, as you just said. Look, we're just about out of time, and I do just want to ask for your advice for New Zealanders and for medical professionals. But there was one issue that you talked about, and it was this area around family coercion, which I think, we're really concerned about, is that pressure that family members who are facing a terminal illness feel that it would be the best thing for their family for them to have euthanasia. Can you comment on that from your experience?
Yes, this was an example of a person whose partner sent an email to the palliative care team, saying that the partner was concerned that their spouse was being pressured by an adult child to take the VAD medication. And the story was that this adult child had returned from overseas to say goodbye to the parent and had come in with the expectation that within the 2 to 3 weeks that the person was visiting Australia, that the parent would take their medication and the child would be there when they died. But in fact, the prognosis was one still of a number of months, and the spouse was not yet wanting his partner to act and take that medication. So family pressure was being applied by the child. The coordinating physician for the VAD legislation was invited back by the palliative care team and asked the patient very directly in front of everybody, do you feel pressured by your child to take this medication? So, of course, the patient said, no, I don't feel pressured, because they were going to protect that child. But within the week, they did take that medication, and the partner was left in bereavement, feeling angry and aggrieved, feeling that they'd missed out. And the child, of course, went back to their country where they had a job and moved on from it all. This has happened, I think, in every legislation. There was a famous case in Oregon. You could look it up, Bob, the Kate Cheney case. In this case, a relative flew in from another state in America and pressured their mother to take the medication, Kate Cheney, and the Oregonian wrote it up extensively. Well-studied case by Foley and Hendon, and it was a classic example of family pressure being applied. I'm here to say goodbye to you. Take this medication now, and that's the kind of thing that can go on in the background and shortens life, spoils life, and is a clear example of family coercion.
And that was one of the biggest concerns we had, was around the coercion and the fact that the legislation in New Zealand just says that the medical professional has to do their best. That's quoted from the legislation, do their best. But there's no measure. I mean, from your perspective as a professional in palliative care, how do you detect coercion?
It's very difficult. You get hints of family argument. Here was somebody volunteering it, and the case was pretty clear, and yet the doctors responsible for the euthanasia took no real action in terms of protecting that woman. They allowed it very much to be her wish. Family pressure is cumulative, it's subtle, it gently occurs. People got busy lives, they've got to get back to work, they're not available to care for the sick. There's lots of ways in which sick people feel a burden to their family. A lot of them express that as a concern. I'm worried I'm a burden to my family. I'm upsetting their ordinary routines. And so families apply pressure very subtly. Doctors are unable to easily pick or change or alter that, particularly as we become more individualistic and potentially selfish as societies, not so involved with caring for the sick and the elderly.
So David, just finally, your words of advice for two groups. The first group is for medical professionals. The New Zealand law says that while a medical professional doesn't have to offer euthanasia or assisted suicide, if a patient requests it, they have to refer them to the kind of the body that has all the registered doctors, and it's only a very small number of New Zealand doctors that want to be part of this. But what's your advice to medical professionals, nurses, psychiatrists, those involved in this area of protecting people?
So I think the first thing is not to take the mention of voluntary assisted dying so literally, but see it as a metaphor for somebody saying, I'm finding this hard, I'm struggling to cope. Use it as a springboard to ask some questions about how the illness is going, what's challenging, what lowers the morale, what might we be able to do to help this person pick their morale up, keep in touch with a life that's fulfilling and meaningful, or where they stay in touch with roles that are important, like being a spouse, like being a parent to children or grandchildren, staying in touch with the meaningful activities of life and helping people to optimize their quality in that way. Someone thinking about VOD is a hint that the medical care may not be as good as it should be. So how can you improve that medical care? What more can be done to alleviate the burden of symptoms and improve the quality of life?
Yeah.
Can medical care be enhanced rather than letting it go?
Yeah.
Very quick story. Another patient came for a second opinion because their pain was bad. They were talking about VOD at their primary hospital. When they came for a second opinion, they were rotated and put on methadone, a very old-fashioned but good painkiller, and their pain went away. And this person said, why didn't that other hospital put me on this medication? So the two docs talked about that, and the answer from the first doc was, well, the person was wanting VOD. I stopped thinking about their pain control. We were focusing on the paperwork for the VOD. So there's a danger that quality of care slips, and really the medical profession's got to be not distracted by VOD, but sustain optimal, good medical care.
And just finally, what's your message to family members? You have a member of the family who's facing a terminal illness. You know that they know that assisted suicide is on an option on the table now. How do families respond in that situation? How do we counter that pro-euthanasia message that's in their emotions?
You know, I think for families what VOD brings is the person's life being shortened by some months. And families should think about how precious that person's life is and really give them a message that they want to help them, they want to support them, they want to be able to extend their life and keep them in their family for as long as possible. I think loving families would again understand that thought about VOD just as an expression of, this is a challenging journey, I'm finding this a bit hard. And families ought to come in and really optimize their support and ensure that there's good medical care, good palliative care being delivered, good treatment, so that the person's suffering is minimized and the quality of their life is preserved for as long as possible until a natural death eventually intervenes.
David, can I just ask one more question? And it's just around it was a case that was brought up in the argument for euthanasia in New Zealand, and it was around the issue of Huntington's disease. And I know you'd be aware that, and my parents were close to a family that a number of the family had Huntington's disease, hereditary. And it's a terrible disease. And it's a terrible outlook, prognosis. In that situation, it's kind of hard not to argue that someone should have the right just to say, I've had enough. What's your response in those hard case type examples?
Well, here you're talking about what proportion do those cases occupy alongside the risk of doing harm to many other cases who aren't as dramatic or aren't as challenging and testing as the Huntington case. But even then, I think you've got Huntington's just as an example of dementia, really, of the loss of full cognitive capacity, that whether people have mild cognitive impairment or early Huntington's, they have quite a long period of their life where there can still be a lot of happiness, a lot of good experience, a lot of joy in a caring and loving environment. And so the idea that as soon as some cognitive impairment starts to come on, people get a little forgetful, people make a few human errors in such ways, that shouldn't be in my view, the signal to say, oh, it's time we brought your life to a close. I think dementia is greatly feared in the community, and these difficult cases can be put forward as carrying great shame and embarrassment to people. But for the person going through it, there's quite a lot of quality of life that they can still eke out and enjoy, rather than have a premature death intervene and take away that quality of life for them. So I'm all for living life fully and well, living it out, not having a premature death intervene.
David, really appreciate your time. We don't want to hold you up because I know you're caring for people and teaching people to care for people. So we thank you for your insight, and I guess unfortunately both Australia and New Zealand are going to be monitoring this closely. That slippery slope is a real concern, and so that's why we need to watch some of the data that comes out, especially from New Zealand starting just in the last couple of weeks. But thank you for your time and your input, and thank you for your medical service in Victoria.